A hearty good afternoon and welcome to the session on neonatal jaundice. We are glad to have Dr. Raja Reddy among us today to help us understand the topic. He will take us through that and more in this session today. Doctor, you have the stage.
Yeah, thank you. Good afternoon, everyone. This is Dr. Subba Reddy, consultant neonatologist in Apollo Cradle, Jubilee Hills. Today, we will discuss about the neonatal jaundice, which is most common problem seen in the neonates. Coming to the burden of the problem, the incidence of jaundice is among all 85% of term neonates, and almost all preterm neonates can have jaundice during their neonatal period. So, what is the definition of jaundice? When do we call jaundice? Like clinical definition is yellowish discoloration of eyes and skins due to increased total serum bilirubin. That is clinical definition. When we discuss about the standard definition, if the total serum bilirubin in the blood is more than 95th centile of Botany hourly specific nomogram, so then we call uh, the hourly specific TSB value is more than 90%, 95 percentile of the Botany nomogram, then we call that standard definition of neonatal jaundice. So why do the babies will have jaundice? What are the types and what are the causes of neonatal jaundice? And what if we don't treat, what complications the baby can have? What are the symptoms of baby with neonatal jaundice? We look for, and how to treat the neonatal jaundice. All this we are going to discuss in the next few minutes. Uh, like the jaundice is mainly caused because of elevated serum bilirubin. How does this bilirubin is produced in the body? That briefly we discuss. Then we discuss about the types and the causes of the jaundice. So bilirubin is mainly produced from the due to destruction of the heme containing proteins. The main heme containing protein in our body is red blood cells. So due to breakdown of heme containing proteins, the biliverdin is produced in the body. So this biliverdin is reduced to bilirubin, and this bilirubin is binded to albumin and then transported to the liver. There, the bilirubin will be conjugated. This conjugated bilirubin is water soluble, so it can get dissolved and it will get excreted in the bile into the intestines. So unconjugated bilirubin is not water soluble, only fat soluble. So there will be like problem in the excretion of bilirubin. So it can retain in the blood and will cause staining of the mucosal surfaces, resulting in the yellowish discoloration of eyes and mucosa and skin also. So any disturbance or any problem in this bilirubin metabolism can cause jaundice in the newborns. So coming to the types of neonatal jaundice. So broadly we classify them as physiological jaundice and pathological jaundice. Physiological means the name itself indicates that it is non-harmful, but it doesn't mean that baby does not require treatment. So, due to exaggregated natural process, this physiological jaundice can occur. Generally, physiological jaundice will start appearing on after 24 hours of life. Gradually, it will increase and reaches maximum value by fifth day of life. Then slowly it will come down over a period of time. So, why does the babies can have physiological jaundice? Because baby RBCs are will have lifespan when compared to adults only 90 days. Adults will have RBC lifespan of 120 days. So, and increased ineffective erythropoiesis and increased enterohepatic circulation and decreased intake and clearance of bilirubin. These are reasons for the physiological jaundice. So, when we see all these causes, the combined problem is liver immaturity. Means liver is not yet ready or handling the jaundice. That's why resulting in a physiological jaundice. Or bilirubin is not effectively excreted. So generally, this won't become abnormal or will become too high value, causing the brain damage. So this physiological jaundice can naturally settle by itself or may require treatment in the form of phototherapy. Coming to the pathological jaundice, the name itself, it is like pathological. Generally, it will appear on the first day of life. The causes of pathological jaundice and multiple causes can be there that we discuss in the etiology of neonatal jaundice. So this is one classification of newborn jaundice. Like one is either physiological or pathological. Other classification is whether it is conjugated hyperbilirubinemia or cholestatic jaundice. Another type is unconjugated hyperbilirubinemia. So cholestatic jaundice is because of increased direct component of jaundice is elevated means we call that cholestatic jaundice. So unconjugated hyperbilirubinemia, like because of either hemolysis or non-hemolysis, even it can be physiological also. So there are two different classifications. One is physiological and pathological type of jaundice. Other classification is conjugated and unconjugated type of hyperbilirubinemia. So coming to the why the babies will have jaundice. So what are the causes for the neonatal jaundice? So we can discuss them under two headings. Like one heading is like one cause can be one class of causes can be hemolytic causes of neonatal hyperbilirubinemia. When the hemolysis will happen, it can be either because of immune hemolytic anemia or non-immune hemolysis. Immune means there will be antibodies against the red blood cells in the blood. So that is immune because of immune reaction. Like immunity is reacting and damaging the red blood cells. That is immune hemolytic anemia. So what are the causes of immune hemolytic anemia? It can be Rh negative, Rh isoimmunization, which will happen in the Rh negative pregnancy. The second baby can get affected with the jaundice and ABO incompatibility. If the mother blood group is O and babies are having A or B type of blood group, then there is a chance for ABO incompatibility and causing immune hemolytic anemia. We call these other causes minor blood group incompatibility. We call these causes as immune causes of hemolytic anemia because there is antibodies reacting against the red blood cells. That's why it is called immune hemolytic anemia. So non-immune hemolytic anemia. So hemolysis can happen because of antibodies or other causes also can be there. So what are the causes of non-immune but hemolysis is happening? G6PD deficiency, pyruvate kinase deficiency, and sepsis, and sequestrated blood in the cephalohematoma. All these can cause non-immune causes of hemolysis. Hemolysis will be there, but the cause is not immune related. So other causes are non-hemolytic, means there is no damage to RBC, but still the baby is having jaundice. Generally, it can happen in the prematurity. The baby is preterm, the liver will not be able to do the conjugation and excretion, all those. That's why the baby can have jaundice, which is non-hemolytic. There is no damage to RBC, but it is not able to handle, the liver is not able to handle the regularly produced bilirubin. That's why it is resulting in the jaundice. So other causes are decreased feeding resulting in increased enterohepatic circulation. If you are not properly feeding the baby, what will happen is the bilirubin which is excreted into the intestines will be reabsorbed back into the liver. So then it will result in increased enterohepatic circulation resulting in the jaundice. And other causes are genetic causes causing mutation in the UGT gene resulting in Crigler-Najjar and Gilbert syndromes, which are syndromic causes, which will affect mainly the conjugation process in the liver. So the bilirubin will not be converted will not be conjugated. As a result, it can't be excreted in the bile, and so it results in the elevated unconjugated bilirubin in the blood, so resulting into jaundice. So we discussed about causes of jaundice. So the most common cause, what we see in term babies and all, is more of physiological only, either because of prematurity of the liver or poor feeding, resulting in increased enterohepatic circulation. This is in contrary to the adults. What we see in the adults is mainly the jaundice is mainly because of infections or alcohol related liver damage. So because of alcohol related liver damage or infections only, we mainly see the jaundice in the adults. So it is not like that in the babies. So the causes are more of non-infectious. Even infectious causes also can be there. They are not most common. Okay. So what symptoms? So parents will ask, so how do we check that our baby is having jaundice, or like what, when we should be worried and when we should bring back to the follow? So the general symptoms for the physiological jaundice will be like baby will be like poor feeding, lethargy, and decreased activity will be there. If the jaundice is becoming severe and causing to raise the bilirubin level about 20 and all, it can result in the severe jaundice. So what are the symptoms of severe jaundice? Severe jaundice can cause acute bilirubin encephalopathy. Means encephalopathy means like baby activity and brain activity will become less. So as a result, there will be like initial stage, mid stage, and the severe stage of bilirubin encephalopathy, resulting in brain damage. So what we see, the bilirubin toxicity symptoms, encephalopathic symptoms initially are hypotonia. Baby will become little floppy and will not take feeds, and there will be poor suck, and there will be excessive crying associated with opisthotonous posturing. Baby will arch back and will be crying excessively. And later stage, the baby can have even seizures, apneas, and even it can result in the death of the baby. So generally, this can happen with the pathological jaundice. Pathological jaundice due to hemolysis, like mother negative blood group, baby positive, like that, or any ABO incompatibility. Immune causes generally rapidly rise to this bilirubin encephalopathy. So we monitor bind score, bilirubin induced neurological dysfunction score, for the assessing neurological damage and monitoring the baby. So before these symptoms occur, we treat the baby. So how to monitor? So how will you monitor and check the jaundice? So we clinically assess the jaundice by Kramer's method. Although it is not like suggested, clinically we assess by assessing by pressing the skin over the forehead and the sternum and releasing. At least for 20 seconds we press and see. If it is deeply stained, and then apart from the clinic, and where the jaundice is there, we assess whether till the lower abdomen or up to the thighs or into the palms and soles. Then other method is non, like without involving the prick, we just measure the cutaneous, like skin level of bilirubin by TCB machine, transcutaneous bilirubinometer, which will assess the jaundice in the skin. It doesn't involve any prick. We check over the forehead and the sternum, and this machine will give the rough idea of the bilirubin. So confirmatory is always checking the bilirubin in the blood. Even though the TCB mission have certain limitations, at high jaundice level, if the jaundice is more than 15, it won't show accurate. In the dark skinned people, it may show little high, and in fairly skinned people, it may show little low. So we clinically and with the TCB mission we assess, and then confirmatory test is always doing the serum bilirubin in the blood. So uh, after assessing, like these are the basic investigations we do initially. If this TSB value is above the phototherapy range, then we consider about treating the baby with phototherapy. So there are two type of charts to monitor and plot, like to assess whether the baby should be treated or not. The two type of charts are, one is nice charts from the UK and American AAP phototherapy charts from the USA. We here follow AAP phototherapy charts for monitoring the and for initiation as well as monitoring of the phototherapy. So these AAP phototherapy charts are gestational age specific and hour specific, based on how many how many hours of the baby, like how many hours of life, based on the baby hours of life, and what is the TSB value. We plot and decide whether the baby requires treatment or not. Initially, the old previous AAP phototherapy charts used to have only three specific cutoffs for the, like the chart will be like this. I don't think so you can clearly see. So there are three lines which are for the each gestational age, and these are the hours of life. And on the y-axis you can see bilirubin. So based on the hours of life, we plot where the bilirubin. So you can see this chart is parabolic. So if the hours of life is increasing, the TSB value where we initiate the phototherapy also will increase. So some parents will ask like, my baby is having 14 jaundice. Other baby is having, like my relatives baby had 16 and 18 also. Still they have not required treatment. And why you are considering treatment for my baby? So it is mainly based on how many hours of life we have done the bilirubin test. So if it is early, even lower cutoff will be there. You can see that chart. No? So it is like parabol, it is rising. So after 7 days, it will be flat. Like even if the value rises, we have like fixed cutoff. Okay. These charts were revised recently in the 2022 chart. We have separate charts. Not sure whether you can clearly see. So these are the recent charts where you have, in that only three lines are there for the each gestation, like gestation. In this separate lines are there for each gestation, like 35, 36, 37, and 38 and above one line. So, and with risk factors and without risk factors, we used to have same chart previously. Now they have given two charts separately. So, risk factors in the sense, these are risk factors for the neurological dysfunction. So, if these risk factors are present in the baby, there is a high chance for the baby to get neurological damage at earlier, like little lesser values also compared to babies which are not having these risk factors. So, what are those risk factors means? Acidosis, hypoalbuminemia, sepsis, and Rh isoimmunization, G6PD deficiency, and sepsis. So, if these risk factors are there, there is easy, like even at lesser level of bilirubin, the brain damage can happen. So, babies with risk factors will relatively have, with even though with the same gestation, means two babies were born at 37 weeks. That one baby is having risk factors, another baby is not having risk factors. So both are at 48 hours of life. If baby with risk factors is having bilirubin of 12 and without risk factors baby is having bilirubin of 14, we start treatment for the baby with risk factors even at 12 because they are at risk. Okay, this will be for in the initiation as well as monitoring. We continue this chart only, like AAP phototherapy chart. So that is for the treatment monitoring. For the preterms, even further gestation, there are separate charts are available which we use for the initiation and monitoring of the treatment. So, so the treatment modalities available for the jaundice are either phototherapy or exchange transfusion. So other treatment will be discussed later. So how does phototherapy works? Phototherapy, how do we provide and how does it works? We are going to discuss briefly. Phototherapy is providing UV light to the baby for decreasing or treating the jaundice. So this will be provided by in our setup, in our unit, we have LED phototherapy units and uh, fiber optic Billy blanket. So which are little advanced compared to the old fluorescent units. So the advantage with this LED units and the fiber optic blankets are LED units will not generate much heat and they are a little more comfortable and more effective for the baby. And fiber optic blankets, we can directly keep the baby on that blanket and can provide the phototherapy. So, is there any side effects of phototherapy? Like we generally cover eyes and genitalia when providing the phototherapy to the babies, and other minimal like regular monitoring is required. There is a chance for hyperthermia if you are not supervised while giving phototherapy, and phototherapy rash and increased stool frequency both are common during the phototherapy treatment. So we assure the parents about those two things, and there is nothing to worry because damage caused by the jaundice is more when compared to the side effects of phototherapy. Okay. So other treatment option, if now the recent recommendation is to provide the phototherapy with less distance and cover the maximum area, preferably with the LED phototherapy units only. So if it is not improving despite starting the treatment with phototherapy and giving other measures and feeding the baby continuously, if the jaundice is not coming down and increasing abnormally, then the next treatment option available is exchange transfusion. The name itself indicates we will be exchanging the baby's blood, which will remove effectively the bilirubin from the serum of the baby. So that will be done using like if it based on the type of for what we are doing the exchange transfusion. Rh negative pregnancy, then we take O negative PRBC, then we suspend them in AB positive plasma and do the double volume exchange, which will effectively clear the bilirubin from the blood. So that is exchange transfusion. The other treatment modalities which are at the level not having much evidence, like for using IVIG for the severe jaundice. So the level of evidence is at level C, which is not quite effective, and the risk when we assess with the usage of immunoglobulins for the decreasing severe jaundice is less. So generally we are not using immunoglobulins here. So other queries generally parents ask is whether the sunlight exposure can decrease the jaundice. The answer is yes as well as no also. So because sunlight will have all type of rays, including the UV light. So when we expose the child, it will work and it can decrease the jaundice. But the answer is no. Why? Because if you are exposing the child without supervision in the summer or in severe sun exposure, can cause sunburn or heat burn, and baby can have hyperthermia. And if you are exposing the child in winter, it can cause hypothermia, which are more severe problems. So, and exposing the child to sunlight should not delay getting the medical attention. So, if the baby is in the phototherapy range, require phototherapy, better to get the phototherapy in the hospital, and they should not delay the treatment just because they are exposing the child to the sunlight. So, so among the main treatment options available is one is phototherapy, and the other one is, if not coming down, exchange transfusion. Usage of drugs, there is no clear evidence for usage of drugs for decreasing the jaundice. So what will happen? What are the complications of neonatal hyperbilirubinemia if you are not treating or severe jaundice? So the sequelae are irreversible. So we generally like prophylactic measures we take and advise the parents to come back for review and follow up we do just to avoid the sequelae of the jaundice. So the raised bilirubin will cause damage to the basal ganglion and thalamus in the brain, which can result in mental retardation of the child. Like choreoathetoid CP, the child can become intellectual disabilities can he can have, and the hearing loss because the auditory nerve height cells are very sensitive to raised bilirubin, which can cause sensory neural hearing loss. And during the like sequelae, which will result in the first year of life, we call them as kernicterus. So these complications are irreversible and preventable also. So better get treated if the baby is having severe ones. So coming to what we do at our center. In our center, generally, we daily monitor weight of the child. We give lactation counseling and assessment for the mothers. And apart from this, we daily monitor the TCB also, and apart from clinically monitoring. So, apart from clinically monitoring the jaundice, we assess the TCB as well as counsel the parents also for the lactation. So, and we advise if the jaundice is little higher or TCB is showing little high, then we do TSB in the blood. Based on that value, we decide whether to go for the phototherapy or ask them to review later. Okay. Yeah. Before winding up, so I just wanted to give 2 points about when do we. The first question parents ask after 1 week or 2 weeks of life is, when will the jaundice comes to normal level? So the jaundice to come below normal, like below 2, that is called normal value. It will take 1 month either in preterm or term. So if the jaundice is in the treatment range beyond 14 days in the term babies, we call that prolonged jaundice. In the preterm, if the jaundice is elevated beyond 21 days in the treatment range, then we call that as prolonged jaundice in the preterm. So preterm, it is 21 days. In the term, it is 14 days. So this is prolonged jaundice. Whenever the jaundice is elevated beyond 14 days, and if there is any increase in the direct component, generally we check for the cholestatic jaundice, which is entirely different topic. We can discuss in some other session. So apart from this, there are two more entities which I want to enlighten the parents: breastfeeding failure jaundice and breast milk jaundice. These are two different jaundice types, which are of more of diagnosis of exclusion. Breastfeeding failure jaundice means the name itself indicates that breastfeeding is inadequate, resulting in increased enterohepatic circulation. As a result, the bilirubin will be reabsorbed into the blood, causing jaundice. So these babies generally will be having like weight loss will be there, and there will be history of feed inadequacy. So babies also will be losing weight. There will be no hemolysis when we do the blood test. And breast milk jaundice. This is another entity. When you have to differentiate it from the breastfeeding jaundice, generally breast milk jaundice, the babies will be thriving well exclusively on the mother milk. This is mainly because of beta glucuronidase in the mother milk. This is the etiology for the breast milk jaundice. So, how do we differentiate them from the breastfeeding jaundice? Because breast milk jaundice babies will be gaining the weight adequately, and they will be like whenever you stop the breastfeeding, the jaundice will rapidly come down within 48 hours, and there will be no hemolysis in the smear when we see. And generally, we don't suggest to stop the breastfeeding in breast milk jaundice. We advise to continue the breastfeeding naturally. By 3 to 12 weeks of life, the jaundice will come below the treatment range. Never it will become pathological. So when we consider stopping the when we consider the risk versus benefit of stopping the breast milk for the jaundice, we suggest to continue the breastfeeding. So yeah, any other queries you have, we can discuss them now. Yeah, if there are no queries, we'll wind up this session. Okay, thank you.